This is the third in a series of 3 podcasts where we'll go over the most high-yield overdoses found in children. We'll continue our Goldilocks format. Today, the porridge is just right, or so it seems. Today, we'll talk about those ingestions that don't particularly present with the toxidrome. The child looks just right for now. But there are some ingestions that we just can't ignore. We'll talk about how to deal with acetaminophen, iron, warfarin, sulfonylureas, and the dreaded colchicine overdose. Time to see if the 3 bears have anything left in their cottage. That's safe, that is.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. The triage nurse asks you to see a 2-year-old who maybe drank some cough and cold syrup. Mother shows you the label, and it's guafenicin. Okay, well, the side effects are just drowsiness alternated with jitteriness, but no, you read it more carefully, and it includes acetaminophen. The child looks perfectly well, just like every acute Tylenol overdose. What now? Well, this happened just 30 minutes prior to arrival. The toddler found the solution in a lower cabinet in the kitchen, and before Mom knew it, she had it in her mouth, on her clothes, and on the floor. So impossible to know the quantity. The pitfall here is failing to recognize that the mixture contains acetaminophen, or paracetamol. I'll just say Tylenol. Since liquids are so much easier to get down than pills, a good slug of cough and cold syrup may represent a significant overdose. Tylenol is the friend that can kill you. It's generally safe. We give it to babies, after all. You may have warm memories of your mother or father or grandma or auntie making you feel better with it. It was touted as a wonder drug in the 1950s when it was first introduced as a substitute for aspirin because of the rising incidence of Reye syndrome. Our liver keeps us pretty safe, but we have our limits. Teenagers and young adults may intentionally overdose, and we take those seriously no matter what the context. Toddlers and preschoolers may explore and take a bit of a swig, and usually those patients don't ingest enough. But again, the mistake is not investigating. Usually parents underdose infants, usually because they've outgrown the last recommended dose and they want to be careful. But of course, there are people out there who intentionally overdose their infants, so just stay alert as to the context of the presentation. Adolescents and adults sometimes run into trouble because they aren't aware of dosing limits. They take Tylenol too often or combine medications that contain acetaminophen, for example, some opioid combinations that contain acetaminophen, and they unknowingly add that to their acetaminophen load by taking it separately because, well, it's all safe, right? Chronic overdose can be a problem as well, but we'll touch on that in a minute. Acetaminophen has a very high bioavailability. It's absorbed almost completely by the GI tract. And that's great in recommended dosages, and any potential small, tiny little overdose, any of the problematic byproducts can be cleared by a happy, healthy liver. In a true overdose, though, the liver is overwhelmed by our friend N-acetyl P-benzoquinone. That's the stuff that messes you up. You may have heard the cool kids call it NAPQ. NAPQ can build up because of too much acetaminophen, because of not enough metabolic clearance, or problems with clearing free radicals at baseline. So the stereotypical person that couldn't handle too much Tylenol would be the elderly person with liver failure. Young children without comorbidities tend to do well because their livers haven't taken so much of a beating yet. How do we dose correctly? Well, Tylenol can be given 15 mg per kg per dose every 4 to 6 hours, no more than 75 milligrams per kilogram in 24 hours. The trickier thing nowadays is whether to use ideal or actual body weight. This remains an unanswered question, but the safeguard is, as with any medication, we use the pediatric weight-based dosing until we reach the maximum adult dose, and in this case, 325 milligrams to 1,000 milligrams per dose. So there's a wide therapeutic index here, but no more than 4 grams per day in someone who has a healthy liver. Now, this then leads to the question, what is the threshold toxic dose? If you have to remember any number, it's 150 mg per kg. That ends up being about 10 grams for an adult. Again, Tylenol has a very wide therapeutic index. You can push it and push it to the limit, but once it's reached, the consequences can be deadly. We'll come back to that number, 150 milligrams per kilogram, in just a moment. Acetaminophen toxicity is sneaky. There are really no symptoms until it's too late. Classically, there are 4 stages to Tylenol toxicity. Stage 1, usually for the first 24 hours, no symptoms. Maybe some generic nausea or malaise and mega overdoses, but most people feel just fine. Stage 2 is 24 hours to 72 hours, and they're starting to feel not so great. Maybe some right upper quadrant pain, some nausea, vomiting, LFTs and PT are up. In addition to hepatotoxicity, you can see some kidney and pancreas toxicity. Stage 3 is 72 to 96 hours after an overdose. Liver failure, renal failure, multi-organ system failure, and possibly death. Stage 4 is after 96 hours, recovery, slowly, if you make it that far. Grim, I know. The patient I worry about is the troubled teen who got very upset, took a bunch of Tylenol, went to sleep, felt fine, then a day or two later starts to have symptoms and comes to see you. If you don't appreciate the patient's full biopsychosocial model, you may not elicit that history and you may miss it. This is why any overdose or unintended exposure needs a workup. Well, how do we proceed? Most of the time, they're going to come to you within a few hours of ingestion. And you still have a little wiggle room as long as you recognize what you're dealing with. Luckily for us, we have an acetaminophen toxicity nomogram. The nomogram starts at 4 hours after ingestion. We have up to 8 hours post-ingestion to decide antidote or not, which is very helpful. So as an example, a teen comes in after her mother discovers an empty bottle of Tylenol with pills scattered all over the room. We figure out that she likely ingested 2 hours ago. We actually wait to draw the blood at 4 hours. Why? If we take a sample now, too early, we may underestimate that Tylenol level. It feels weird to wait, but study after study that show that all people do well if they're treated by hour 8 post-ingestion. There's really no difference in treatment, hours 4, 5, 6, 7, or 8. You don't want to commit someone to days of medical hospitalization with IV drips of an antidote if it's not necessary. So we wait. Labs are drawn at hour 4. Results by hour 5. Her acetaminophen level is 170 micrograms per ml. Do you remember that magical number of 150? Well, 150 milligrams per kilogram is the threshold toxic dose. That is, if you're under that dose, you're likely fine. If you're over it, you're at risk for developing hepatotoxicity in a few days. So 150 milligrams per kilogram is the potential toxic dose, and it just so happens that 150 micrograms per ml at 4 hours post-ingestion is the serum acetaminophen level threshold for treatment. Regardless of where you find yourself working, please be sure to check with your particular lab and how they report your units. The Rumac nomogram will help to plot out exactly at what hour post-ingestion you find the treatment line. So at 4 hours post-ingestion, the treatment threshold is a serum acetaminophen level of 150 micrograms per ml. But later on, at 8 hours, that treatment line, the threshold, is a serum concentration of 80 micrograms per ml. We can be fooled and we can get inaccurate information from patients and other collateral sources, so just be extra skeptical here and err on the conservative side. Always use that nomogram to be sure that you can trace the treatment threshold depending on what hour you're in post-ingestion and what serum acetaminophen level that corresponds to. Two other common pitfall scenarios are when we don't know when the ingestion occurred or if we suspect a teenager is lying to us. I know, it's never happened before. In the first case, if we can't verify when the ingestion occurred and it's possible that we can't get back our serum concentration before the safety deadline of 8 hours post-ingestion, we need to bite that bullet and treat immediately before we get that serum concentration back. So that's the teen or adult who got drunk or high, took a bunch of pills that may or may not include acetaminophen. Last night, they're brought in, or in the morning, they're regretful, or whatever. Get that IV in and start the antidote. Another not uncommon scenario is the teen who's had some suicidal ideation or who is at risk for this and swears to you no ingestions. We trust, but we verify. And lo and behold, there is some acetaminophen in the blood. To me, it doesn't matter how much because we have unreliable info. Even if it's 50 micrograms per ml, this teen is getting admitted for the full treatment course. Which brings us to that sweet, sweet magical antidote. What is it? Well, to scavenge the N-acetyl P-benzoquinone imine, we can give N-acetylcysteine, or NAC. NAC is a precursor to glutathione, a potent antioxidant. NAC conjugates NAPK, rendering it less toxic. In addition, NAC helps to sulfonate acetaminophen that has not yet been metabolized, taking it out of circulation. If that weren't enough, NAC, the wonder drug, increases nitric oxide concentrations. Nitric oxide, of course, improves blood flow in the microcirculation, which helps to mitigate the ischemia caused by Tylenol toxicity. And acetylcysteine is really a wonder drug. Well, do you remember that magic acetaminophen number again? Remember? 150? 150 mg per kg is the potential toxic dose of Tylenol. 150 micrograms per ml is the serum concentration at 4 hours post-ingestion. That gives us the treatment threshold. And 150 milligrams per kilogram just so happens to be the acute, immediate dose for our friend N-acetylcysteine. It's nice when things are just easier to remember. Now, that's the IV dosing, which nowadays is the best way to go. If for some reason you're forced to use the PO route, then it happens to be 140 mg per kg. Not a big deal, but it's important that the patient take it all. We used to put down NG tubes into people and give a promotility agent before the IV form was more available. Again, IV is safe to use and it's probably considered first line if you have it. When in doubt, treat. But if you have time, get a level between 4 and 8 hours. Look up what that serum concentration means at what hour post-ingestion on the Rumac-Matthew nomogram and treat accordingly. An 18-month-old just got into his mom's iron pills that she takes for her menometrorrhagia that seems to be resolving. It's unclear how much the toddler could have taken. By report, they seem to be those small pills with a sweet enteric coating. Luckily, it's hard to eat enough iron accidentally as a toddler to do much damage, but we still need to do a little investigation here. In older children, adolescents, and adults, intentional overdose of iron is the sepsis you can drink. Iron comes in various preparations: ferrous gluconate, sulfate, fumarate, just to name a few, each with its own proportion of elemental iron content. Try to find out what type and how much was possibly taken. Of course, enteric-coated preparations may seem safer, but really they just cause more confusion about when we expect a peak in toxicity. We don't really know the toxic dose of iron, but we think that most people who ingest less than 20 milligrams per kilogram usually have no symptoms, maybe a little GI upset. More than 20 milligrams per kilogram of elemental iron, though, is associated with toxicity. Remember, we're not talking mg per kg of the preparation taken. We're talking mg per kg of elemental iron that's found in those pills. They're always on the package, and you can easily look it up. For example, a typical normal adult dose of 325 milligrams of ferrous sulfate contains 65 milligrams of elemental iron. Now, I had to look that up. There's no way to remember this. So if a 14-year-old who weighs 60 kilos takes 10 tabs of ferrous sulfate, some math, boop-a-da-boop, probably going to be okay, but we need to calculate it. 10 tabs of this preparation at 65 mg per tab, that's 650 milligrams of elemental iron. That's about 10 mg per kg, so this teenager should be okay. But what if she had actually taken double that? Or maybe this is a 4-year-old who liked the taste of the candy-coated tabs and ate maybe 10 of them. Or what do we often get as a presentation? Oh, there's about a week's supply left in there. It's unclear. Maybe there's 10 tabs left, as an example. Same dose, 65 milligrams of elemental iron times 10 tabs. Again, 650 milligrams total elemental iron. But if you take that 650 milligrams divided by his 20 kilogram body weight, that's 32 mg per kg, above the toxic threshold of 20 mg per kg. So it can get bad fast. Now, that's a lot of math, and my brain doesn't work well hearing about formulas. I'm more visual, and I need to see them. But my point here is that find out the actual preparation so that you can figure out how much elemental iron was ingested. 20 mg per kg is the beginning of bad. What can iron do to you? Well, the ferric ion, Fe3+, is toxic to cells. You get mucosal necrosis and bleeding, capillary bed oozing, lipid membrane melting, Krebs cycle crashing, vessel dilating, and serum proteasing. In summary, you get shock, vasodilation, metabolic acidosis, multi-organ system failure, coagulation cascade chaos, the sepsis you can drink. This usually starts out benign enough. The iron is ingested and causes some local GI upset, some nausea, vomiting, cramping, then within hours progresses to all of the cardiovascular, hepatic, and other system failures. The important thing to remember is that peak serum concentrations usually happen within 4 to 6 hours after overdose. The shock that you find here is terrible, and just like the shock in sepsis, it's multifactorial. Hypovolemic shock, in this case from both fluids and blood losses, distributive shock from vasodilation, and cardiogenic shock due to the iron's myocardial depressant effect in large doses. In sepsis syndrome, all of these factors usually present concomitantly, but in iron overdose, it usually progresses from hypovolemic to distributive to cardiogenic, but that timeline is all over the place. Since the level of toxicity varies from person to person, and we haven't studied it as well as, say, Tylenol overdose, iron poisoning is a clinical diagnosis first and foremost. If you think that there was enough ingested iron to cause damage, then that is enough to treat. To help others who will be caring for this poisoned child, you can be a team player and get a serum iron level. Just don't let it detract you from treatment. If it is very low, then maybe that's helpful at 4 to 6 hours. But if it's elevated, then just treat. It's hard to correlate. I mostly use it to verify ingestion when needed and to see if we're anywhere near toxic levels and to trend it out. But if this patient has symptoms or enough concern that they took a large dose, remember 20 mg per kg or more of elemental iron, then you just treat. So get a serum iron level, hopefully at 4 to 6 hours post-ingestion. Remember, that's when the peak concentration occurs. You may want to keep the patient longer if this is an extended release and test them again later. You want to get a CBC, chemistry panel, VBG, LFTs, PT, PTT, INR. You're also looking for blood loss, metabolic acidosis, liver and kidney dysfunction, coagulopathy. If your serum iron is less than 350 micrograms per deciliter, then generically you're okay. Anything else and you're at risk for toxicity. If you get plain films, you may see the iron radiographically, but please don't use that to rule out ingestion. You got to poke the kid. Well, what to do now? If you have a potentially toxic ingestion of iron, then give what? Deferoxamine. It binds free iron and excretes it safely in the urine, giving you a lovely vintage vin rosé, a rose-colored urine. Remember that since iron is a metal, activated charcoal can't adsorb to it. In awake patients, you can place an NG tube and do a whole bowel irrigation if you needed to. Make sure you have an IV and resuscitate. These children often go to the ICU for monitoring and frequent lab testing, even if they look pretty good when you make that diagnosis, and even if you quickly and effectively give the antidote right away. Now, of course, this is just the beginning of treatment because of the context that brought the patient to take a potentially lethal dose, and also because iron is sticky. It can form bezoars and adhere to the mucosal surface. Sometimes repeated endoscopy is needed to fish all of that out. A 2-year-old boy is brought in by his mother because she thinks he ate some rat poison. Okay, what happened? They have a rat problem. They put out some rat poison, but the rats seem to be too smart for that. They typically don't go for it, so a family friend gave them some great advice to coat their rat superwarfarin in peanut butter. Guess who also likes peanut butter? Yep. The boy found some on the floor and ate it right up. Superwarfarin is called that because it's very concentrated. It's very potent as an anticoagulant that causes spontaneous hemorrhage in little rat brains. It's unclear what they do in those doses to humans, but who wants to wait to find out? Luckily, even the smallest toddler is bigger than any rat, and most accidental exposures don't result in significant coagulopathy. If you really have to know, they inhibit vitamin K epoxide reductase, which is what's needed to regenerate vitamin K stores. Of course, an acute inhibition of vitamin K means that the vitamin K-dependent clotting factors are, remember, 2, 7, 9, and 10, and protein CNS. They can't do their job, and you get thinner blood. Since the concentration of superwarfarin in any product varies, this is where poison control comes in. If this is an unintentional exposure in a healthy child, usually no testing is going to be helpful at that time. They should, however, have follow-up within 48 to 72 hours to get their INR checked. With intentional overdoses, though, all bets are off, and these people can get really sick. Get baseline labs, pretty much all of them. CBC, chemistries, UA for blood, DIC labs like plasma fibrinogen, serum fibrin degradation products. Go looking with CT of the head for any symptoms, and ultrasound or CT if there's any concerns for thoracoabdominal bleeding. Look up the dose of vitamin K depending on what INR elevation is and the child's weight. For severe bleeds, you can give FFP, or prothrombin concentrates. A 15-month-old girl found something interesting behind the couch this afternoon, and from across the room, Father saw her put it into her mouth. He yelped, which scared the child, and it looks like she swallowed it. They arrive wanting to know what it was and what should be done. You're asking yourself the same question. Mother, father, and child live together. All is well. No one else lives there. No one else is on any meds. You ask about candy, cereals, beads, anything that could have been what she took. Button batteries? No, it wasn't shiny. It wasn't small, round, or white. You're still going to do a lateral x-ray to make sure there's no button battery there. But, okay, we're really not getting very far. Anyone visit the home recently? Yes. Grandma and Grandpa watch him a few days a week. After some investigation, Grandma has diabetes and takes a pill, and Grandpa has gout. Uh-oh. A few calls later, and it looks like we're talking about either a sulfonylurea for the diabetes or the dreaded colchicine for gout. These are both on the list of one pill can kill. The sulfonylurea is the more manageable of the two possibilities. The main point here is that the child's blood glucose can drop even 12 to 24 hours after ingestion, so this is 100% an admission for frequent blood sugar checks and a continuous infusion of D10. Colchicine is the scarier of the two possibilities. It's used for gout and works very well in adults with flares. It works so well in gout because it decreases the response of granulocytes and other inflammatory cells. It's a direct antimitotic agent. It stops cell division in early metaphase by halting mitotic spindles from aligning and dividing. It literally works at the cellular level. In small doses, the rapidly dividing cells of inflammation are the only ones that are affected, and the host is otherwise fine. In overdose, all of your cells are frozen in time, and that can cause multi-organ failure. At 0.5 milligrams per kilogram, the fatality rate is 50%. Double that, double the mortality. So a typical tab for adults is 0.6 milligrams. A 10-kilogram toddler swallowing one pill could kill him, although not with certainty. But a teenager who takes a handful, now we're talking. So what do? Unlike all of the other Goldilocks stories I've told you, this one does not have a happy ending. There is no antidote. It's aggressive, supportive care, and lots of warm thoughts. The main treatment is prevention. Our role as emergency physicians is to take that extra step and talk to parents about medication safety to prevent this kind of potential tragedy and to try to suss out any potential ingestion in the vague presentations that come in every day. I routinely talk to parents about getting on a child's eye level, crawling around the couch or chairs or tables and just looking around at that level. Grandma might have visited a few months ago, but the broom bristles haven't seen that couch leg since. But you know who has? Little Susie or little Jimmy. It's scary. When you get a moment, go yourself and make a toddler's eye view sweep of your own home. You may just find something that could save a life. When Goldilocks visits, eats a bunch of, well, something, and she seems okay. Maybe she's not right. We talked about ingestions that are tricky because someone's been eating my med and they look just right for now. Acetaminophen, your friend that can kill you. Even though the therapeutic window is wide, check the level between 4 to 8 hours. If you're out of the window and suspect possible intentional ingestion, just start the NAC. There's little downside, and potentially you could save that adolescent's life. Use the Rumac nomogram to figure out what is the treatment threshold at what hour post-ingestion. The magic number? Potential toxicity at 150 mg per kg. At 4 hours, 150 micrograms per deciliter serum concentration, and the dose of NAC that you should give is 150 mg per kg. Iron toxicity. The sepsis you can drink. Anything goes, but check the amount of elemental iron. If more than 20 mg per kg, this is potentially toxic. Patients may go from asymptomatic to GI upset to multi-organ system failure in a few hours. Treat with deferoxamine to get it out of that urine. Superwarfarins from rodenticides. This is most toddlers, accidental exposures. They're not harmful. The best care is to get a coagulation study at 48 to 72 hours. Intentional overdoses need vitamin K, scan that brain, scan that body, and really if anything's askew, give them FFP or PCCs. With any ingestion in a toddler, look it up. Make sure it's not one of those one pill can kill meds. And clean up your place, people. This concludes our 3-part series of Overdose. Too hot with psychomotor and vital sign elevation. Too cold with depression of mental status and vital signs. And seemingly just right when things look fine but they're not. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.